Good afternoon, everybody. I welcome you to this session, the fifth edition of our How I Do It series. And today we have an interesting topic of pouch surgery for ulcerative colitis. And I think today we are celebrating the vaccination day also. It's an important day for the country, and I hope this vaccination brings better times ahead medically for everybody. And without wasting much time, I would request Dr. Pradeep Rabella, who's our moderator today, who's the president of IASG, to moderate the session. Request Dr. Pradeep Rabella, please.
Thank you, Dr. Govil, and good evening, everyone. And today we have excellent senior faculty here, Dr. Haribhakti, Dr. Sujay Paul, and Dr. Raj Pandian here. And today we'll be talking mainly of the technical aspects of the pouch surgery. So all of you know this pouch surgery was invented by Sir Alan Park from St. Mark's as late as 1970. And this is the major revolution in the surgical treatment of ulcerative colitis. So it has led to the acceptance of surgery in ulcerative colitis as the patients can avoid a permanent ileostomy, which was the norm those days. And we know roughly 1/3 of the ulcerative colitis patients ultimately require surgery in their lifetime. And a lot of advances happened in ulcerative colitis surgical management since 1970. There are various types of pouches like J pouch, S pouch, W pouch, etc. And then the staplers have revolutionized and made it much more simpler using the double staple technique in constructing the pouch. And then came the minimally invasive surgery in the creation of this pouch, and the patient's recovery is quicker and the outcomes are better. But in spite of these many advances, the morbidity of the pouch surgery tends to be around 20 to 25%. And roughly 3 to 7% of these pouches have to be taken down at some time or other in their lifetimes based on this large series. And the morbidity and the pouch outcomes are related mainly to regarding selection of the patients, timing and staging of the surgery. And most important, of course, is the surgical technique, which dictates the morbidity and even the long-term outcomes of these sports surgeries. And today we have Dr. Haribhakti, Sujay Paul, and Dr. Raj Pandian, who have their extensive experience on creating these pouches. And they will be discussing mainly the technical aspects of the pouch creation. First we'll start with the colonic resections, how it is different from the conventional technique before creation of the pouch. So I request Dr. Raj Pandian to briefly discuss about the resection procedures before creation of the pouch. Dr. Raj Pandian, please.
Good evening, everybody. Hope everybody is viewing my PPT.
Yep.
Okay. Thank you, Dr. Pradeep. First of all, I thank Dr. Deepak for giving me this opportunity to speak regarding the pouch surgery. So I am now going to give how we are doing in our center the total proctocolectomy with the ear pouch and anastomosis. Of course, as Dr. Pradeep rightly told, initially it was open approach. Now, after the invention of the laparoscopic for the past 2 decades, more than 2 decades, so we have been doing total proctocolectomy by laparoscopic method, and it has been proved well in the literature as well. Of course, everybody knows the indication is mainly the inflammatory bowel disease, mainly the ulcerative colitis. Of course, other than the inflammatory bowel disease, you have FAP, attenuated FAP, and HNPCC, and double malignancy. So this is the FAP and attenuated FAP, and this is the ulcerative colitis. So if you take ulcerative colitis indication for TPC, usually it can be a chronic ulcerative colitis where it is a failure of medical treatment. A patient could not tolerate the medication for a long time, so that will be the indication. In acute setup, there may be various indication for surgery. suspected perforation, toxic megacolon, and refractory bleeding. So these things an acute setup. Of course, in acute severe ulcerative colitis also, we can do laparoscopic procedure, whereas in toxic and other perforation, you have to go for open as well. So coming to the pouches, as correctly told, various pouches there. You have a J pouch, S pouch, W pouch, and lateral pouch. What has been universally and many consultants, many surgeons wish to do is J pouch, which is easy to do, and as the invention of a stapler, double stapling technique, it has become very easy, and we can teach our postgraduate easily when compared to S pouch and double pouch. Of course, we will be going on talking about these pouches, all these, throughout these presentations. Just few words regarding the J pouch. It is quicker and easier. Whereas after the J pouch, bubble frequency is higher when compared to the W and S pouch. But you can use anti-diarrheal medication if you are using the J pouch. Whereas S pouch, where you have a long efferent spout, like more than 2 centimeter need, in particular obese patients, it can be used instead of J pouch. Whereas W pouch is more capacious, but both S and W pouch are more difficult in pouch evacuation. More than 50% will be end up in doing a digital evacuation. So there are various methods of pouch creations, whether open or lap. So extracorporeal pouch formation, in case if you are mobilizing the colon rectum laparoscopically, you can do the pouch formation intracorporeal as well using a lap port, or you can use the transanally or even transvaginally as well. So the anastomotic technique, as you said, you can have a hand-sewn pouch and anastomosis, or a double stapling technique if you are using a circular stapler. So what are the instrumentation I'm going to use for the laparoscopic method? The special instruments like a harmonic scalpel, ligature, of course, stapler, linear and circular stapler, and a special instrument long backpack forceps. So the theater setup is like this. Most of my colorectal case will be in this position because it is easy. So you have to, the surgeon has to shift on both sides. Initially, you'll be standing on the right side of the patient, then you go to the left side or in between the legs. So in the semi-lithotomy position. And this is the port placement for a total proctocolectomy. I usually tell my postgraduate it is nothing but a combination of extended right hemicolectomy plus ultra-low anterior section. So if you say this, it is a total proctocolectomy. So initially you can start mobilizing the right colon first, or you can start mobilizing the left colon. If you start left colon, then you can finish the difficult part first. So you can start from the left side, mobilization of the sigmoid colon, then sphenic flexure, then you can go for the inferior mesenteric vessels, rectal mobilization, and division with the linear stapler. Then you can go for the right right colon mobilization. The main thing is you have to divide the ileocolic vessels at its origin. Of course, in all right hemicolectomy, we'll be doing the same thing. So after that, we can do a mini laparotomy. That is not a mini laparotomy, it's through the mini incision through the ileostomy site, exteriorize the bowel, and they divide the terminal ileum and creation of ileal pouch. Then again create the pneumoperitoneum, then ileal pouch and anastomosis with circular staple with protective ileostomy. So the pouch and anastomosis could be side-to-side anastomosis with a circular stapler, pouch and an anastomosis. So this is the theater team setup with the port placement. So first I am going to show a laparoscopic TPC with IPA, which was done for a FAP. Then followed that, I will be showing a TPC with IPA for a acute severe ulcerative colitis. This is a 38-year-old male patient who was diagnosed to have a sigmoid double malignancy in a FAP background. So first is the mobilization of the IMA. So ligation of the IMA. So after IMA division, then IMV ligation. That is the IMV at the inferior part of the TJ flexure or the inferior part of the pancreas. So that medial to lateral mobilization, then lateral attachment of the sigmoid colon and the descending colon mobilization, then entering the mobilization of the rectum, preserving the nerve plexus, lateral and anterior. So reaching up to the pelvic floor. So division of the anorectal junction just in front of the pelvic floor. There is a levator and a muscle you can see. So nerve plexus very important. So then sphenic endoscopic tunneling technique. And division of the ileocholic artery at its origin, dissecting separately ileocholic artery and vein. So this is a very important step so that the pouch will reach nicely without any tension. And the division of the releasing the DJ flexure as well. So these are the two important steps we usually do for all IPAA. So followed that the right colic and the middle colic. You can have the right and left branch of the middle colic separately. But usually for FAP we do like any radical CME with CVL. So many times we have come across in FAP patients after the specimen, even before patient, after specimen, we have a T2 or T3 lesion as well. So with this, through the incision, through the ileostomy site, after removing the specimen, ileal pouch has been made. At the apex of there is an enterotomy at the apex of the pouch. Both rim has been opened. So I use the endo-GA stapler. You can use the open 100 as well. 100 and then one endo-GA. This is the endo-GA stapler. I'm using blue in this case. If it is thicker, I use blue. If it is thin, I use white color. 60 endo-GA stapler. So usually 3 will be using so that it will come around 15 centimeter. The pouch size should be around 15 to 18 centimeter. So the anvil is introduced at the apex of the. Then it is introduced inside. So you have to make sure there should not be any twist in the pouch while you are docking it inside. So docking and closing. So you have to make sure the pouch, there should not be any twist in the pouch. So this is the pouch and anastomosis done. So then drainage tube kept and there is a diversion loop ileostomy. Always I will do. So this is how we do. So next case, I'm just going to show a TPC in acute severe ulcerative. This is a 30-year-old gentleman who has been diagnosed recently for a month and he has been treated outside hospital for more than 25 days with the IV steroids and other cyclosporin, and he was not responding. And he was in debilitated stage. And with the MDT, we decided to undergo a total proctocolectomy. And when he came here, we did the colonoscopy. The colonoscopy pictures shown here. And it shows a diffuse ulceration with the polypoid mucosa with the loss of vascular pattern and multiple deep ulcers with slough and pus noted in the sigmoid colon with the narrowing of the lumen and friability, mucosal friability noted. Future suggest of severe ulcerative colitis. And CT scan shows like this. You can see the edematous bowel, large bowel wall, and it was getting shortened. So in view of deteriorating general condition, his albumin is very low and he was having a dyselectrolemia, he was tachycardia, he was passing more than 25 times loose stools with the blood. And this is the condition once we go in. So this is what it looks like. Sorry. There was some hypoalbuminemia, there was ascitic fluid was there. There was inflamed, shortened, large bowel. So initially we mobilized the left colon. And this is very short. So we are, see, left side colon, we are keeping close to the colon. When you come to the right side, you have to divide the ileocolic vessel at its origin so that the pouch will reach without any tension. The simple measurement is whenever you put a scope and laparoscope, you see all the bowel is going to the pelvis, and if it is difficult to bring it out, then that is the case, there will not be any problem. So most of we have done like more than 156 cases so far. So we never come across any patient with the difficulty in forming a pouch, except one or two cases where there was previous surgery was there, and there is a stricture formation in the small bowel mesentery. So any patient without previous surgery, there will be very unlikely that the pouch will may not reach the pelvic floor. So now the colon getting mobilized, the mesocolon is getting divided using LigaSure. So that is the middle colic vessel. So the hepatic flexure has been mobilized. Previously, the splenic flexure got mobilized. You can see the diseased one. Now we are going to the pelvis. You can see I am not going to the TME plane. In acute setup, we used to go for an intramesocolic plane because the young fellow, so he has, it should not disturb his nerves, so that will affect his sexual activity. So he has reached the pelvic floor. So the divided the rectum at the rectal junction using the endo-GA stapler. You can see the inflamed, diseased large bowel. So, and all the toxic fluid inside the small bowel has to be washed. So we are making a posting at the apex of the pouch, possible apex of the pouch, around 12 to 15 centimeter size. So keeping that one end, the pouch is getting washed with the betadine solution, saline, and then it is divided at the end. So now it has put inside after the pneumoperitoneal peritoneum and the pouch and anastomosis. So make sure, particularly in a female, while we are doing this connecting the anvil, there should not be any vaginal wall coming while we are doing the docking the circular stapler. And make sure there should not be any twist while making the anastomosis. So this patient went on well in acute. So after 2 months, this was a diversion ileostomy. So he showed a good improvement within 10 days. So 12th day got discharged, And after 2 months, I did the ileostomy reversal. Now he is doing fine. Now 1.5 years now. Just I'm not going to detail because the following speakers will be touching these things. A few points regarding mucosectomy with the double stepping anastomosis.
Subsequently, if I have to lengthen the pouch, I can sacrifice the main SMA and then use this ileocolic as an alternate feeder to the pouch. So I preserve the ileocolic artery in complete arcade and as close to the bowel as possible, right colon, and also preserve as much long ileum. At the junction of IC, we transect it. That is as far as the colonic resections. Colonic resections, the vascular, we don't reach up to the pedicles. We closer to the colon, we ligate. The other thing is initially our tendency used to be in the mesocolic planes. Of late, after the trial published intramesocolic excision, the pouch functions is supposed to be there. There's a lot of debate on this, whether you go in the TME plane, which is surgically, it's technically much more simpler and easier. But of late, some studies are shown it's more bloody if you go in the mesorectal, intramesorectal plane. But apparently, the pouch function, pouch sensation, compliance is supposed to be known. This is what the literature says. And we did find that some of our patients where we have gone through intramesorectal, we did find that the pouch function apparently appeared to be much more better. I don't know. I want to ask the other analysts what is their experience, whether they have any intramesorectal experience there.
Yeah. Yeah, at present, as you said, sir, better take out the diseased mesorectum if you are operating for a patient, a chronic ulcerative colitis. As I showed in this patient, young, just 1 month duration, you have a very thin, then you have to, it is very difficult in case if you injure the nerve, both sexual function as well as bladder dysfunction. So they say if it is in case of chronic ulcerative colitis for long time duration, patient on medication, not with a failure of medical treatment, or a patient having a dysplasia, high-grade dysplasia in the left colon or rectum, then you have to go in a TME plane because you have to do like a malignancy if you are suspecting. But what the literature says, they were going for intramesocolic pain, all these cases for particularly ulcerative colitis, and they found in a particular where there is a thick mesorectum left behind, if you and all the pouch failure, all the problems post-operative the pouch are due to that disease left out mesorectum. Then they found that it is better to take out the mesorectum in case of a thick mesorectum where there is a chronic ulcerative colitis where you are not suspecting dysplasia, for other reason you are removing that. But still, I feel you have to go remove the disease mesorectum in case if you are doing a chronic ulcerative colitis or for a dysplasia.
Sometimes I feel while resecting the diseased rectum, if you take the entire mesorectum, firing the stapler becomes a bit of a problem at that lowest point. So at that point of time, you may cone down onto the wall of the rectum so that the staple can fit comfortably and you can fire it well. So I think the Cleveland Clinic chaps are the ones who have been popularizing the fact that you can stay the mesorectum along with the rectum while excising the rectum, because they feel that if you leave the mesorectum behind, it affects the capacity or the compliance of the pouch subsequently. Otherwise, technically, I am sure for the laparoscopic version of the proctectomy, it'll be easy to take the mesorectum along with the rectum rather than dig in between the wall.
Yeah,
and
I agree with
mesorectum.
this. After the laparoscopic era, you have a better visualization and you have better clarity. You have more like 10%, 20 times magnification, and the nerve injury is less common. So we can do a TME plane very nicely, even in a chronic ulcerative colitis.
So the only disadvantage I see with removing the mesorectum is the neural injury. I think that's the main risk because most of these patients are very young. And with the laparoscopic approach, going into the TME plane definitely is much easier technically because you are avoiding all the vessels into the mesorectum. And the benefit is that you can visualize the nerves. We make an active attempt to visualize the nerves, just like we make an attempt to visualize the ureters. On the left side, we make an attempt to visualize both the hypogastric nerves, and in most cases, we can see them well. So we can remain anterior to these nerves and avoid at least the hypogastric nerve injury. I'm sure that the parasympathetic, the nervi regentris, there will be, that dysfunction of the rectum will happen in any case, even if you go into the mesorectum or you go outside the mesorectum. But in my feeling, if you leave the mesorectum, a lot of bulk is there in the pelvis, and it may affect the future pouch expansion because the pouch does expand significantly over a period of time. So what we do is that we, in the upper rectum, when we enter the plane, we go into the TME plane, identify the nerves, but right from the lateral ligaments, we start coning in because the lower mesorectum is not very thick vascular. So then we start coning in earlier, and as Sujoy said, we would go, and the lower part of the rectum will be very close to the rectum. So because the lower mesorectum is not very thick. So that's the combination that we use, and I think that works quite good, at least.
The main thing is pouch, though you keep in the TME plane, if you're going down, you should avoid injuring the anterolateral part of the adenovirus fascia. That is the main thing while you are making the, pouch TME, pouch surgery in a young patient ulcerative colitis.
You should remain.
So we should, that is a very, very, very important because most of the patients are young. So keep close when you are going from the lateral to anterior aspect in the circumferential aspect.
Yeah, I think once you cone down, as you go,
yes,
you just walk on.
So automatically, yes, automatically if you go. So because the lower third of the rectum doesn't have much mesorectum. So automatically, once you go there will not be mesorectum. Then only you can put the stapler. With the mesorectum, definitely you can't put the stapler. So that is the indication that you are correct.
As we are running short of time, now we have a pouch creation, technical aspects by Professor Haribhakti. Go ahead, Haribhakti.
Yeah, I'm just sharing the screen. Are you able to see the screen share?
Yeah.
Okay.
Yeah.
Okay, so I'll be talking about the pouch creation, basically. And already Raj Pandyan has shown us what are the types of pouches, and J pouch is the most commonly used pouch. Now, the mesenteric vascular division that we were discussing, what Dr. Pradeep was saying. So we also follow the same principle. We go very close to the ileocecal junction, and then we go very close to the right colon. So we'll not take this route, which is through the ileocolic pedicle, but we'll go very close to the right colon and preserve the cecal branch as we go towards the right colon. And then what we do is we will still go very close to the right colon and preserve the entire marginal artery till the middle colic artery. So this way, what happens is essentially that we preserve the entire marginal artery on the right colon, so that in case then if there is any problem with relation to the pouch length, then we can actually sacrifice the ileocolic, the right colic, and get a better supply of the distal part of the ileal pouch from the marginal artery. So this way we can get an additional blood supply. We can then sacrifice the terminal part of the SMA, the ileocolic, the right colic, finally, if there is any need. So with this, it is a good option. And that's why most of the times what we do is that we create the pouch extracorporeally and do also
We lost your audio.
Sanjeev, we cannot hear you.
हाँ संजीव सुनाई ऑडियो नहीं आ रहा है.
Your audio is not.
Dinesh, can you help?
This is about a 35-year-old lady who had the first stage subtotal proctectomy done. Subtotal colectomy done following an episode of acute severe ulcerative colitis. Here we are just ligating the pedicle. Open procedure is being pedicle supplied to the Hartmann's pouch, and we're mobilizing the Hartmann's pouch. You can see the anterior aspect is on the right, and you can see the rectum posteriorly, and you can see the bluish vaginal fold which is coming out in the dissection. You have to be very careful in applying the linear stapler here, making sure that the vaginal fold is well away and dissected away from the anterior part of the wall, because that can come within the stapler, and this precaution has to be taken even when the circular stapler is being fired. We've used the curved reticulator here to fire, and it is said that if the anterior staple line and the posterior staple line, the positioning is such that there is a bevel in the way the rectum is cut, and in fact this bevel is a good thing to have, specifically when we want to avoid a technical issue in which sometimes you can have a pouch vaginal fistula because of inadvertent incorporation of the vaginal wall in the staple line. So here the firing has been done, and the proctectomy specimen is being removed. After that, the J pouch is created. So I'll skip that part because we have already seen how that is being done. So we mobilize the end stoma and the J pouch is being created, mobilize the mesentery, do the measurements, and create the pouch. We usually go for a 15 centimeter limb. So 2 firings of 75 or 1 firing of 100, along with the firing of 75, is able to give us the adequate length of the limbs of the J pouch. We take these precautionary sutures on the mesenteric aspect so that the mesentery keeps well away from the staple line, and try that. This is an important precaution to take, because if it comes into the staple line, then it can make the pouch also ischemic as well as cause excessive bleeding intra-pouch. So this makes this small trick helps us in keeping the mesenteric aspect away from the stipple line. And sometimes we take this anteriorly just to approximate the cover the suture line for some time. So after we've done the double firing, this is the double firing where the rest of the J limbs are threaded over the blades of the gun, and the second firing is done. After the firing is done, we make sure that we inspect the inner staple line to see if there is any bleeding, and take sutures if required by everting the thing. And then we normally we use the 29 size 29 curved stapler because we feel that the 33 anvil is too big for being accommodated into the hole that we make on the tip of the pouch. And sometimes if you use a 33, it actually encroaches upon the mesentery of that part of the apex of the pouch, and that can make a bad thing to the pouch creation. So we avoid using 33. Here we are seeing that the gun is being positioned in the perineum, and you can see that the point is come, and then firing has been done after approximating the gun. And this is the final look of the pouch in place. We make sure that the mesentery is lying posteriorly. Some people do it anteriorly, but we prefer keeping it posterior. So this completes the open J pouch anal anastomosis after doing the proctectomy. I have two brief clips of the mucosectomy as well as the Hanseon technique, which have been shared by Dr. Pradeep from the Asian Institute of Gastroenterology, Hyderabad. I'll share those and then we can go on to the discussion. Can I continue with that and then take the questions, or?
Yeah, I think so.
Can you enable the screen sharing, please? So the screen, it's visible now?
It is visible, but it's not running.
Yeah. Yeah, I'll just. So this is the everting suture that's taken on the four corners of the anal verge, so that the dented line is seen from the perineal side. Then the scoring marks are put by a diathermy just above the dented line to tell you the lower margin of the mucosal transection. Then, of course, injection of dilute adrenaline saline is done in the submucosal plane to make the dissection easier and lift up the mucosa from the submucosal tissues. And then you proceed using sharp dissection and diathermy along with a good suction device so that the messy field is kept clean for us to proceed with this part of the dissection. And it helps to have a short rectal stump because the longer the stump, the more messy and more difficult and tedious this procedure will become. So this is you can see the cylinder of the mucosa which has been taken out, and it's so nicely done without any buttonholing. This is a remnant of that area of the rectal cuff which has been denuded of the mucosa in preparation for the subsequent anastomosis. I'll share the last thing, which is the Hanseon anastomosis. Again, Dr. Pradeep has been kind enough to share that. I'll just go on to that in a moment. So this is a very short clip. Is the screen seen?
No, not it.
Can I proceed with this?
The screen is not seen.
Not seen. Okay.
Yeah, now.
Now?
Yeah.
Yeah.
Yeah, okay. So very small clip, but this shows that the pouch has been created, and this is transcendental suturing being done with the opening and made on the apex of the pouch, along just above the dentate line, where we saw the previous mucosectomy margin in the previous clip. So these sutures usually, most people prefer Vicryl. We can use PDS. The Vicryl needle helps you, the 2-0 Vicryl needle helps you in taking these bites on the wall of the aspect. You proceeded using the, after the eversion sutures are cut, actually the anastomosis has been done already, and the pouch and everything has been inspected. We can, of course, always insufflate, put in a Malicose catheter into it, and then I'll stop the video here. And so you can insufflate. I'll go back to my presentation. I'll just highlight a few things on the presentation, and then we can take questions. Do you have the time, Dr. Pradeep? Or
Yeah, okay, go ahead, no problem.
yeah, okay. So this is basically the same thing which we have reiterated: how to cut the proctectomy specimen, how to stay close to the wall to apply the linear stapler before firing, and before the J pouch and the rectal stump is approximated, the perineal assistant is told to be gentle with the gun, because twice or thrice it has happened that the assistant has pushed a bit too hard and the entire stipple line has given away. So that is a danger which can happen. But even if it does happen, you'll have to actually close the stump, taking interrupted sutures from the abdominal end. Most of the time, it is feasible to do it from the abdominal end. Then the handling of the mesentery has already been talked about. How to assess that your pouch is going to reach your intended rectal stump, and the best way to do that, one of the best ways to do that, is to see whether the apex of the pouch is going at least an inch beyond the pubic ramus. The reach is different for a hand-sewn technique and for a double stable technique, because of the rectal cuff of 1.5 centimeters above the dentate line, less of a reach is the problems are lesser with a double stable technique than with a hand-sewn technique, or in the cases of redo pouches where the reach becomes a bit of a issue. And in that sense, some of the stalwarts of pouch surgery have always said that a surgeon should be conversant with just not one technique of pouch creation, that is the J pouch, which is most fashionable all over the world, but also the S pouch, because that gives you additional 1.5 to 2 centimeters in the snout. That is the efferent snout of the S pouch, which enables it to reach deeper into the pelvis than a J pouch normally reaches. And this is how you transluminate for identifying the vessels at the time of J pouch creation, and to see that the reach is adequate and tension-free. These are the scoring incisions that are made over the mesentery, over the SMA, which can allow at least 1 centimeter, 1.5 centimeters of length to the apex of the pouch. And the number 2 out here indicates the place where a segment of the ileocholic artery can be removed, and that gives you some length and pliability to the apex of the J pouch. This is the same thing again. And this is what Dr. Pradeep was alluding to, that if you leave the marginal arcade behind, so the supply is coming from the right branch of the middle colic artery, we can be more liberal with the transaction of the right colic, the ileocolic, and even the distal SMA, because that can give you a length of almost 11 centimeters, in which case a reach is not a problem. And this, you have to anticipate problems in patients who are obese, well-built and tall, males. And the second place where you have problems with the reach is when you are dealing with a situation where you have to do a redo pouch or a salvage pouch surgery. These are the basic, this is a study which shows how much length can be available by the various maneuvers that have been done. The ileocolic artery segment can give you 3 centimeter additional length. If the SMA is cut distally and after preserving the arcade from the ileocolic, around 6.5 centimeters additional length can be available. And in the last one, which I have already alluded to, around 11 centimeters. So these are the pouch configuration. Again, we are not going to waste time. This is the basis of the double stable technique. And you do the insufficiency test to see if there is any leak. This is the schematic representation of the mucosectomy technique. And there is another way of doing the Hansoon technique, which is the eversion technique, where the rectal pouch is actually everted by using a sponge holder, and it's cut at the dentate line, and the pouch is also sewed and then repositioned into the perianal region. Of course, this entails more stretching of the anal canal and may lead to dysfunctional problems in the post-operative period and incontinence. Whether when to choose the staple technique and when to choose the Hansoon, basically most, in 85 to 90% of the cases, the stapled IPA is good enough, the double staple technique. But in those situations where you're dealing with dysplasia in the lower 2/3 of the rectum, or there has been a rectum in malignancy in the rectum, in those situations, it's better to do a mucosectomy. Our philosophy is that if you have a malignancy in the rectum, we actually do not advocate pouch in those patients. But there are centers who do pouch even in those conditions, specifically if they can ensure that the malignancy is totally curable. And then you can actually resort to mucosectomy in those situations. And of course, in patients with FAP, you need to do a mucosectomy. This is a pouchogram done about 6 weeks after the pouch creation. And normally the follow-up protocol is that every 3 months on the first year, 6 months in the second year, each visit you assess the continence frequency, whether there are any symptoms of pouchitis. If there are, then you need to do a pouchoscopy. A pouchoscopy is done on an annual basis for those patients in whom inadvertently the cuff has been, a longer rectal cuff has been left behind, or in those patients where dysplasia was an issue preoperatively. And pouchogram is a must before any the ileostomy closure, which is usually done about 8 weeks after the second stage. I'll stop here. And we can take questions, and if the time permits, we can go into some principles of salvage pouch, redo pouch, etc.
As we are running short of time, we'll start off with Haribhakti, then we'll come back at the end and take
Sure, sir.
Okay, Haribhakti?
Yes, Pradeep, I'm ready.
Yeah.
Okay, I'll start. Okay. Can you see the screen?
Yeah, we can see the screen.
Yeah.
Okay, fine. So Suja has made my life easier. Already, these issues have already been discussed and shown how you first identify which is the best place for the apex of the pouch by pulling it different locations and allow it to come at least 2 centimeters below the pubic symphysis, and then select that area, then put stay sutures on that area. Mesenteric scoring has also been, and there are some other maneuvers like manipulating or dissecting around the DJ flexure and doing some dissection around the supramesenteric vessels into the root of the supramesenteric vessels at the third part of the duodenum. There are some ways we can slightly increase the length of the pouch. DJ flexure, in our opinion, has not much help, but scoring around the supramesenteric vein and the artery around the third part of the duodenum does help. Especially, it will help to prevent the supramesenteric artery syndrome, which is one of the rare complications of this procedure. The pouch folding, whether to fold it anteriorly or posteriorly, also does matter, so that the pouch can gradually at least have 0.5 or 1 centimeter, but most of the times the pouch is folded posteriorly and the mesentery is anteriorly, so that that's how it lies much better into the pelvis. So let me go to the video now. Yeah. Okay, so this is how we create the extracorporeal pouch. We take the mesentery or mesocolon with the ligashure very close to the colon. The specimen is removed. This is the laparoscopic assisted pouch at the area where we take 2 stay sutures first. That is the apex of the pouch which has been identified. And then, as Sujay showed, we take another 2 sutures. We generally create a 15 centimeter pouch by 2 firings of staplers, the blue cartridge. But now recently what we have converted is to 3 firings of a 60 millimeter cartridge, because in 60 millimeter we get a white cartridge, which is generally not available in the 80 millimeter or the 75 millimeter linear cutting staplers. So the white cartridge that we have found it's better because it causes a better hemostasis and the risk of bleeding into the pouch has come down. We have had 2 patients in whom we have had a pouch bleed after a blue firing of the pouch. So this is how the pouch is opened at the apex of the pouch. And what we do is that the first thing that we do would be to, aspirate whatever is there from the ileum. And then we like to wash the distal ileum to remove any fecal material or stool particles, to clean it. Number 1. Number 2, this will also help for the staplers to guide in much easily, because sometimes with the dry mucosa, the staplers also rub and they cause folding of the bowel and sometimes the mesentery also. So with this, and the other precaution that we take is we apply a little bit jelly on the stapler arms so that it lubricates very easily as it passes into on both the sides of the on the J pouch. So after this, we'll put in 1 by 1 the stapler arms into the J pouch. How to give the counter traction? It is better to pull the mesentery so that it will not just pull it, but it will push it down so that it doesn't come while we are tightening the stapler. So that is how we check all around that it has come completely to the end of the stapler before firing, so that at least the full use of the stapler line is being taken care. While firing also, traction, counter traction is essential to get a good smooth firing. And then finally, after some hold, we will fire so that there is a good hemostasis, there is a good traction. This is the blue cartridge, which is an 80 millimeter cartridge. So 2 firings of 80 millimeter cartridge will form a pouch of about 16 millimeters of length. But then when we take the purse string and we excise it, at least a 1 or 2 centimeter loss happens when we get a double stapling anastomosis. So here you can see that the second fire of the blue cartridge, again making sure that the mesentery does not come in, and the stay sutures are also helping us to get a good lie of the pouch. And this ileum is very flexible because over a period of time, this pouch enlarges significantly. And finally, then we will again wash the pouch, distend it, see for the capacity, and also look for any bleeding. So this is something like, doing a 3 swab test, and we can check whether there is any bleeding. If there is any evidence of bleeding, then we would like to, evert the entire pouch mucosa by using multiple Babcocks, putting it on the suture line, and then gradually 1 by 1 everting the entire suture line. With this technique, you can actually see the entire suture line. You can mop and look for any bleeding problems, because bleeding problems are very difficult to handle post-operatively. We have had 2 cases of bleeding. In one, the patient had a massive bleed into the pouch with a large hematoma, and that caused a little disruption of the pouch also. The second patient we managed by transanal suturing of the bleeding site under vision from below. So bleeding is a difficult problem to manage, and that's why now we have resorted to using white cartridges, which does not come with these regular staplers. So after we are satisfied that there is no bleeding from the pouch, we will close the apex of the pouch. We prefer to use a 28 millimeter cartridge because that's the the smallest available cartridge, and it generally fits well because most of the times the rectal cuff is also quite small, does not accommodate a large stapler head. The other issue is that sometimes, with a large stapler, there is a risk, as Sujoy mentioned, of going through the staple line from below. And that's why we prefer to use a smaller anvil. And generally, stricture is not a big problem unless these patients develop some pouch anal anastomotic leaks or complications, then only stricture happens. But generally, we try to close the stoma earlier. We close it at 2 months after the surgery. And at that point of time, there is some disuse, mild narrowing or fibrosis. We generally dilate it with a finger when we close the stoma. So stricture is not a major issue. So here a 28 millimeter anvil is placed into the pouch, and with a purse string it is closed. Now there are different ways of taking a purse string. You see here that this is a full thickness purse string which is taken. There's other way people use to take a seromuscular purse string. Either of the way, it is a good technique. There is no, there are just two techniques of taking a purse string. We generally prefer to go full thickness so that it gives, when we tighten it, it gives a good crimping effect and tightens the purse string around the stapler anvil. So after the purse string is tied, we generally, what we do is we keep a very long end of the purse string so that helps us as a marker of the orientation of the pouch. Because we start taking the purse string always anteriorly to the staple line. So this will be as our lamppost or our marker when the pouch anal anastomosis is being created, so that there is no eversion of the pouch. Now, after this is done, before putting the pouch back into the abdomen, what we do is we remove the entire small bowel out and put the pouch as the first thing into the abdomen, and then place the entire small bowel back in the abdomen before we create a re-laparoscopy. Because that is the time that the bowel may get entangled and the twisting or of the mesentery can happen. So this is how we put the pouch back and then place it in position, make sure that the orientation is the same, so that we confirm, we go to the distal part of the ileum and see that there is the orientation is fine, alignment is okay. In the pouch, generally we first make sure that there is a adequate reach. We will put in a finger and see that the pouch is reaching adequately. Most of the times that's not an issue when we have made sure that all the precautions have been taken. While we are putting the perineal part of the stapler also, it is gently done with the rotating movements. One may dilate it with a single or even with two fingers, a gentle dilatation of before we put in the stapler. And sometimes if there is any extra pressure, then what we'll do is we will put 3 either Babcocks on the anal canal to give a counter traction to put the stapler so that it does not go through and rupture the staple line of the perineal rectal cuff. So once under vision, the pouch is the stapler is inserted, and make sure that we see the orange part on the stapler head, because that is make sure that completely it has been inserted. The uterus can be held with either instruments or with with a suture to the anterior abdominal wall. You can see that part of the orange line that is there, so that the entire the assembly is put in. Make sure that alignment is okay before we start tightening, and then after that we start tightening the pouch. Make sure that the green firing line comes in line, and then the pouch is and the stapler is fired with the full thickness, and will keep the hold for some time so as to achieve a good hemostasis and compression. And then finally applying the lock. We prefer to use these tiltable anvils, which are good so as to when we remove the staplers, they get tilted, and that will help in removal, easier removal, so that it does not disturb the pouch, does not get entangled. And while removing, also gentle to and fro movement is done in the direction of the pouch pelvis as it comes out. Once the stapler is removed, it's better to check both the anvils properly, make sure that they are of a good thickness, they are equal, and they are completely circular. There is no eccentricities, and that will help us to at least judge that how is the anastomosis is. And of course, after that, we'll always put in a finger, we'll always put in a catheter and do a gentle saline, inflation and check for any leaks by doing a leak test. And we make sure that the vagina is out of the harm's way before we fire the stapler. So these are all the standard precautions, that there is no twist or rotation on the mesentery. There is no internal hernias behind the small bowel mesentery of the pouch of the other small bowel. And these are all the precautions that we need to take to avoid for the complications, because the complication risk of this operation is quite high. As Pradeep initially mentioned, it is almost 25 to 30% of morbidity. Most common complications being bowel obstruction at multiple sites in the abdomen. This could be pouch-related sepsis, some anastomotic leaks, and so this have to be taken care and prevented as far as we can. In our experience, after we have converted from hand-sewn to stapled anastomosis, the complication rate of pouch anastomotic leaks has come down. Even the functional outcomes later on has improved. And I think the double stapling technique has really, helped us to reduce the morbidity and mortality of the pouches. But still, obstruction is a problem. The sepsis rate has gone down. Selection of the patient, whether to do a single stage, 2-stage or 3-stage of the pouch, that is also important to reduce the morbidity of the pouch. So with this, I finish my presentation and we can take questions if there are any.
Thank you. Can you hear me?
Yes.
Yeah. Thank you, Haribhakti, for an excellent demonstration of the creation of the pouch. And before we take questions, let us have the panel on some of the technical tips and difficult situations, so that before we move on to the question and answer sessions. And we have Dr. V.K. Kapoor also here, so he can also actively participate in this discussion. Dr. Kapoor, welcome to the...
Good evening, sir. Good evening, Dr. Sir.
Thank you. Good evening.
Good evening.
The panelists, I'll ask, suppose nowadays with the double staple technique, the problem of pouch not reaching doesn't arise. In the era where you used to do hand-sewn anastomosis, mucosectomy was a big challenge of getting the pouch down of about 2 centimeters, 0.5 centimeters below the pubic symphysis, so that you can do a comfortably hand-sewn anastomosis. So with the staple technique, actually we never even, I hardly remember doing any lengthening procedures in an abdomen where no surgery has been done. So, but by chance, if there's a breakdown of the anastomosis, probably you have to convert to a hand-sewn anastomosis, you still land up in a problem of lengthening. So, are there any special techniques each one has to lengthen the pouch? Sujay, to start with, we can start with Sujay, then Raj Pandian.
So all of us have emphasized on the ways we can tackle the mesentery and the ileocholic artery or the distal part of the superior mesenteric artery, preserving the arcades, using the help of translumination and using bulldog clamps if you really have to ligate either of these vessels, so that the pouch viability is ensured when we are doing all these maneuvers. As you said, rightly said, with the double staple technique, I hardly recall any situation where actually I was caught out thinking about what to do when the pouch is not reaching, because most of the times I hadn't had any problem. But these are the only things that we can tell, and there will be situations where you're totally caught out, where none of the lengthening measures have helped you, and in those situations, it is said that you can just leave the most dependent part of the pouch that you have created, just leave it hanging without, of course, opening the bowel and creating the stoma upstream, so that later on the mesentery will lengthen and you can actually live to fight another day to, create the anastomosis. So that's all I can say.
Yeah, I think that's an important point which you made, Sujay, that you leave the pouch and then come back again, you give a stretch and then wait for some time and then go on. I think the most important, I feel, should be that when you do a colectomy, you should plan out for probably a necessity for lengthening and then preserve as much as the arcades as much as possible, so that you do not know when the second stage, when you go in, you might have to do the, you lengthening and you have to sacrifice. The trick of your transillumination is a very good technique where you can see the vessels clearly in a this thing. But how do you handle these vessels? Cannot be laparoscopy. How do you transilluminate during laparoscopy? Rajpandian, can you?
Yes, sir. So, in my point of view, what the experience I had in the past, like 150 cases, all are laparoscopic. In the open era, I feel maintaining, as you said, the right branch of middle colic you can have and closely you can save. But I feel only few cases which I show in the acute setup, acute ulcer, we did a TPC and we are going close to the mesocolon. I think there is not much problem in case of acute where the patient is having very thin, easily it is going to the pelvis. Whereas same patient, if it's a obese, if it is not reaching, then it is a problem. But nowadays, doing a surgery TPC in an acute setup is becoming very, very decreased. In my point of view, probably because of the increase in the medical management. Probably what we have come across is a chronic ulcerative colitis, which we have to do probably will be end up for dull lesion or dysplasia. So you have to do a surgery like a malignancy. So you have to go and take a vessel at its origin. So I feel all our cases we have taken a ileocolic at its origin. So there is no point. That is a ileocolic, if you take it origin, definitely most of the time it will reach very well beyond the pelvic floor. Even you can do very nicely. You can do pouch channel anastomosis. We have done in a young female patient, pouch channel anastomosis even after mucosectomy for a FAP. And reaching the pelvic floor or reaching the anal canal is not a big problem. So by laparoscopically, as I told, once I put the scope, if the bowel is going to the pelvis, and main point is we want to take the bowel out of the pelvis while doing the surgery, while releasing the rectum. So that itself will give me the bowel. This bowel is going to come without any problem. And as everybody told, once the pouch is reaching beyond the pubic symphysis, usually I measure like more than 5 centimeters, there is no problem at all. And another thing, if you remove the mesorectum, then easily it will come. If you leave the mesorectum, then the lengthening will be a problem. So that what previously, like 20 years, 30 years before, everybody was leaving the mesorectum. That is the reason why even if you need a lengthened pouch, because it become narrow. And suturing is also, it was difficult. And another point in laparoscopic method, as Dr. Sujoy was telling, the perineal surgeon. So before division, somebody from the perineal surgeon can give a push from the perineum. So you can have that extra 1 centimeter for division of the rectum near the anorectal junction, just at the anorectal, the transition you can have. But usually the pelvic floor, the levator ani pelvic floor will be the area where we will be dividing for this case. Unless I go for intersphincter resection, then you can extra 0.5 to 1 centimeter I can have, so that once I divide, it will go. You can't see it. Actually, somebody has to push. Otherwise, you will not see the rectum. In that case only, while the perineal surgeon should be very, very careful while pushing the circular staple, as Dr. Sanjeev Haribhakti was telling. So in that case, so what happens? So sometimes somebody has pushed fast, a little bit more, and if there is a give way of the rectal stump, so there will not be partially you will be seeing. So with the position, with the stapler, circular stapler on position, you can suture it with the interrupted suture. Then you can fire. So rather than leaving it fully. So you should not give more pressure, but don't remove the stapler. You keep that. So you suture it, then fire it. That is the one. If you have a full staple as gave way, there is no way you can suture from inside because it's very deep. Whether in open technique or laparoscopic, you can't do. You have to go for colon anastomosis. So that is the only way. These are the two things I could say in this case.
Sanjeev, any trick up the sleeve for such a situation where pouch can't reach it?
Yeah, so if the pouch will not reach, then all these maneuvers that we have already discussed, I think those are the things that can be done. and the scoring incisions, more mobilization. And I'm fortunate that I've not encountered. I have encountered 2 or 3 situations where there was difficulty, but then finally the pouch could reach and we could do the anastomosis. And as you rightly mentioned, with the stapled, it is not a big problem. It was a big problem in the hand-sewn era. So I think now that problem has come down. And fortunately, most of these patients are ulcerative colitis are all thin and lean. The mesentery is so flexible and they don't have much fat in the mesentery. So it easily comes down, and it comes down quite easily, goes and reaches. The problems will occur in FAP, obese patients. Those who are, these are the patients where this problem can happen. But fortunately, those kind of patients are very rare. FAP pouches are much rare than ulcerative colitis. Most of the pouches are done for UC. So fortunately, I've not come across a situation where I would have to come out and say the pouch could not reach and I had to do an stoma. Fortunately, that situation has not come. But, we have to be prepared for a situation like that.
So like previous surgery, for example, the patient has undergone some previous surgery, or there is some, as you said, some right hemicolectomy for a colon cancer. Later, you have to do a completion colectomy, patient with a desmoid tumor. So these are the patient we may have a difficulty if you feel a TPC. In that case, you can assess on table. You do if the rectum is okay. So as I told, I have one patient with post right hemicolectomy with a desmoid tumor, both in the mesentery as well as in the rectus. So after going in, after mobilization, I feel like if I do a pouch, definitely it's not going to reach. So I left part of the rectum there because I know even if it's a FAP cases, the rectum was okay. So I leave like 4 or 5 centimeters of the rectum and did a iliorectal anastomosis, end to side iliorectal instead of making a pouch. So patient went on well. So in that case, we can do like you can save the rectum. So if you are a FAP, whatever rectum left behind, easily you can surveillance, but you should tell the patient you have to be in close surveillance. That is the only thing you can keep. But all the patient, if your pouch is not reached, then we may have to get a consent for a permanent ileostomy as well.
The biggest challenge, like Haribhakti has told, is the weight.
Yeah, that is also possible. But I feel you can just leaving and doing a diversion ileostomy. Later we can go. If everything was done laparoscopically, yes, it is possible. After some time, after a few months, you can go. But dissecting that ileal pouch from the pelvis, again, you can damage the pouch. That is because post surgery, if there will be a lot of adhesions, there is a high possibility that you may not be able to do the pouch. You can do a hands-on anastomosis.
Thank you, Raj. So what Haribhakti has highlighted is, I think you don't let your patient put on weight. Particularly when you stage it on steroids, the moment it is controlled, they start putting on weight. It's the biggest challenge when you stage these patients. So you should be careful in instructing your patients not to put on too much of weight, because that will make your pouch surgery more difficult in the second stage when you go in. Now we have Dr. Kapoor and Dr. Deepak here. So here for their viewpoint of any other tricks which they have their own up their sleeves in such a situations where they can't, the pouch cannot reach.
Dr. Kapoor.
Since there are students and inexperienced surgeons like me for pouch, 2 or 3 instances I would like to tell them where I committed a mistake, and a very grave mistake. One was that when you pull to apply the stapler to divide the anorectum, if you pull too much, the stapling could be very low, and this happened in one case. And then we found it very difficult to accommodate the EEA stapler into the small anorectum. So before you apply the stapler to divide the anorectum, you must either put your finger, Hagas or proctoscope to make sure that you are dividing at the right place. Second mistake I did was that I tried to stay very close to the colon, the so-called colectomy laparoscopic I was doing. And in that process, we probably caused some thermal damage to the very thin, fragile, soft wall, because this patient was on long-term steroids, which ideally they should not be. Then when extracting the specimen, probably some fecal spill occurred, and this patient went into sepsis, and unfortunately, we lost her. This was an iatrogenic injury. If I had left a little bit of a mesocolon along with the colonic wall, probably this would not have happened. The third was not a mistake, but just an observation that while creating pouch, 7.5 into 2 never becomes 15. It is always less than 15. So we changed to 10 into 2, or you should use 3, as one of you said. Now, I have one or two kind of comments. One is that the pin, especially in a female patient, the stapler pin must come behind the staple line if it is horizontal, so that there is no possibility of vagina coming into it. While doing an open, I thought that when you make the opening in the end of the pouch, if you place 4 stay sutures there with the needles intact, 3, 6, 9, and 12, and then pull the pouch along with these sutures, the alignment becomes good. So that is what we used to do when we were doing open pouches earlier, that these 4 sutures are pre-placed in the pouch in the abdomen, and then the pouch along with the sutures is pulled out. So and if you can mark those sutures, that which is 12, which is 3, which is 6, and which is 9 with different artery forceps, and then in each quadrant put 3 or more sutures in between. But what I want to ask, when you, one of you said that if the pouch is still not reaching, you leave the pouch. I think Sujay said that you leave the pouch in the pelvis and come back. Come back after how much time? Do you have, any one of you have this personal experience that you left the pouch and came back? Or is it just described?
I don't have any personal experience. I was quoting one of the surgeons from Cleveland Clinic, Ramsey, I think, who said this in one of his talks.
Thank you.
Yeah. Yeah, I would just add 2-3 things. One is that while doing the laparoscopic or robotic laparoscopic colectomy, at that time itself, we do a dissection around the SMA so that we get an additional length during that dissection while doing the transverse colon resection. So maybe that helps while making the pouch and taking it down also. That is one thing which probably might help. Another thing is that while making the pouch, most of you have shown that from the ileostomy side to take out, we make an incision separately, maybe around the umbilicus or in the phalansteal area to make the pouch separately and then take it down for the anastomosis. So for that also, if it's already done, the SMA dissection is already done, then probably the lengthening is much easier and you don't have to go back again and do something to extend the length of the pouch. I think these are the things. Another few comments is that the anastomosis, I also use a 29 or a 28 size. I think the reason for that also is that probably the frequency of stools is also a little better if you have a larger size of the stapler. The frequency of stools is much higher in the post-operatively. I think these are the things which I would like to just add. Yeah.
Yes, sir. Kapoor, sir.
I wanted to ask one more thing. When you're doing a mucosal mucosectomy, do you start at the dentate line or do you intentionally leave a centimeter of the anal transition zone above that, what eventually we have in the stapling technique?
We'll start just above the dentate line, sir. Just above the dentate line. Actually, we recently encountered there's a staple misfire, and then and then I had to do a mucosectomy after, I think probably after so many years. This is one of our residents was doing it, so he just inadvertently pushed it much deeper. So there's a complete disruption. So there's no way for us to reapply because it is way down just on the sphincter complex. So I just have to convert it. And it was very technically challenging because there's nothing to hold for the rectum for us to do the mucosectomy from below. So that is another challenge which I faced. Then we have to get the pouch out. So I have to sacrifice the main SMA trunk because fortunately there was a ileocolic arcade was preserved. So we are not sure whether it is circular. So we have used ICG on table to confirm that the blood circulation is adequate till the tip of the pouch. And then after that, we confidently did, which that is one of the new technique which is available, I think, in most of the centers. You can use this rather than the visual inspection is, of course, is good, but sometimes ICG is more sensitive in picking up whether blood circulation is good. You can use it before you sacrifice these vessels for a lengthening procedure. So we'll move on to the next difficult situation. So use a dusky pouch. You're not sure whether the pouch is viable or not. It's 50-50. So any suggestions, tricks for us, whether you go ahead, do the anastomosis, or you wait, like what Suja suggested, you leave the pouch and come back the other day and then do the pouch, or any suggestions, or you want to do augment by any sort of a microvascular, like what you used to do for the neck anastomosis for colon pull-ups. Suja, start with.
So when you create the pouch, there will be hardly any situation where you have a dusky pouch. The duskiness comes when you are actually trying to, fit it to the site or after you have done the anastomosis, because either there is tension or there is some problem with the venous return which creates a duskiness. And it is actually a tricky situation. Then actually you should also see from below how the pouch is looking from inside, because I'm assuming that the anastomosis is already been created. And if it is actually dark and dusky from inside as well, and if we don't have the ICG, if you can have the ICG, you can use that benefit to give you an idea about the vascularity. I think you'll have to take it down and then see if another different segment is available where you can site the pouch and maybe create another one. I haven't tried any vascular augmentation as of over the years, I haven't tried that, but that's another option. But I'm not sure how it will work and when you will choose that. That would be my suggestion.
Haribhakti?
Yeah, so I think if the pouch is dusky, then it has to be taken down. And I would also not go for ICG. I would take down the pouch, and then you can create another pouch from another proximal part of the distal ileum. We have had experience of a couple of cases where we have to redo pouch after long because a rectal cuff was left behind in the previous pouch surgery. So in these cases, in a few cases, we have had to sacrifice the pouch and create another pouch. So that is still possible. And most of the times, this should not be a problem. So I think if there is dusky pouch, and this is a surgery where we cannot take any chance, we should just take down and create another pouch rather than hoping that this pouch will stay or try. See, ICG also does not have any quantification. There is no way we can quantify. And ICG is also a very subjective thing. It's very difficult to make such important decisions based on ICG. So if there is a clear-cut dusky pouch, I would think that it is better to take down and create another pouch, create another length.
I think if you find dusky pouch, first look at your anesthetist, whether the blood pressure perfusion is good or not. Then look for any technical mishaps, which is like rotation of the pouch.
Rotation
is one.
So these are things which you should first look at, any technical things which is done, because these are all correctable things before you decide that I'm going to take down the pouch. And then if still the pouch is dusky or not happy, as Sujaya said, that look at the mucosa, whether it is dark or not, only then you decide to take down the pouch. I think the first one should look at, there's a good perfusion, blood pressure is all right, there is no technical twisting or any loop caught under the pedicle, which is herniated inadvertently, which is producing pressure. So these are all some of the things which you should attend to before you decide that, okay, I'll take down the pouch and go for another pouch. Any other comments from other faculty, Dr. Kapoor, Dr. Deepak?
I totally agree. But I feel at the present era of ICG, after the pouch and anastomosis, if you feel dusky, as you said, we have to rule out the other possibility of kinking and stretching and do ICG. If ICG is reasonably good, I think we can do a diversion diastomy and wait and watch. Many times, because we are taking through a narrow end, because there will be a venous congestion will be there rather than dusky. So you feel the pouch is congested, but once it got inside, slowly it will come out. If you few hours, it will become normal many times. So that should not give a bad, bad impression that it has gone down. But definitely ICG will help to giving a positive aspect that we can leave and do a diverse ileostomy. Of course, on table you can do a sigmoidoscopy or oginoscopy and make sure the mucosa is okay. But even the mucosa is congested, which means that the venous congestion also, the edema congestion may be there. But you can always wait. And as you said, during the surgery, whether patient anytime went for hypotension, or you can ask the patient with hypotension, there may be venous return that can cause also congestion. In that case, also there is a chance of duskiness, and very well we can do a diversion ileostomy and see. But as Dr. Haribhakti shows, if there's a revision of the pouch, as he said, definitely we can make a pouch in the proximal segment as well.
Yeah.
But for that, we have to make sure that before making the pouch, we have a good all the lengthening aspect, whatever addition that the DJ flexor has been relieved, and we can release the superior mesenteric vessels, both anterior and posterior. Make sure it is reached the anal canal nicely without any tension.
I think if we have a dusky pouch, and even if ICG shows good circulation, I would not go ahead with the pouch. I think it's very important that we don't leave a dusky pouch, a doubtful pouch inside, and come out of it. I don't think that is true, because ICG, it's a good technique, but we cannot rely so completely on ICG to leave a dusky pouch inside.
Yeah. So before we conclude, I want all the panelists to give, when will you avoid a pouch? When you say, no, I want to do a pouch. Dr. Sujay, we'll start with Dr. Sujay. When will you say no to a patient in ulcerative colitis that you're not going to offer any pouch to that patient?
One is a situation which I alluded to before, which is cancer within the rectum.
Okay.
It has been not severe dysplasia. If there is a proven malignancy in the rectal stump, I'll not offer pouch, number one. Number two, in a patient who has FAP and has a desmoid tumor, which is complicating your pliability of the mesentery, these are the two areas where I'll not offer. And of course, the third situation where the person is having a poor anal tone, is unable to do this thing, no pouch.
That's fine.
Yes, I agree with Sujay, because if the patient is very old and it's not functioning, if you have anal incontinence, there is no point in having a pouch, because the pouch is going to have more LAR syndrome for such patient. And a patient with who's having think of Crohn's disease, then we can't do a pouch. So that's also, and as I told you before, we have a patient with the FAP with the desmoid tumor, which you can't reach, you can't make a pouch. We have offered like ileorectal.
Yeah, there is a lot of debate on whether you offer a pouch for Crohn's, because there are some people still offering, as long as the patient knows that the pouch failure is to the tune of 50%. But many centers in India are not very keen on doing pouch for Dr. Haribhakti.
Yeah, so incontinence is one. Other issue is about elderly patient with a anal tone is doubtful on a manometry, and in which we are likely to face that syndrome of a very high frequency urgency. These are the patients whom I would definitely counsel the patients for a vis-a-vis a permanent stoma versus a pouch. But Crohn's I would not do. But for rectal cancers, we would like to select these patients. If they are upper rectal cancers, and if they have received a neoadjuvant radiation and the chemo, then and it is not a very advanced stage like a 3B, 4, then definitely for a stage 3A, we can definitely go ahead and do a pouch. Should not be a problem. Because we would like to avoid any radiation to the pelvis after the pouch is created. The concept is that no radiation should be done after the pouch is done. That's why if radiation is necessary, then nowadays, obviously with the neoadjuvant treatment, radiation is always given before the surgery. So that is the only thing we need to take care, that pouch should never be radiated ever, because otherwise then the function will be lost. It will not work. It will not expand. And that when we are doing it for malignancies, we should take care that we don't give any radiation to the pelvis after the surgery.
We also agree that T1, T2 upper lesions where they don't require a post-operative or pre-operative radiotherapy, we might consider pouch only in those patients. Otherwise, we don't do. I agree with Sujay in that situation. But Kapoor wants to make a comment. Kapoor, please.
No, the same thing I wanted to ask from students' point of view, that do we differentiate between upper rectum versus middle and lower rectum? You've already addressed that.
Deepak?
Yeah, I think we've addressed most of the things. There are 2-3 questions which I think most of them are.
Yeah, you can.
Yeah, they've already been covered. Actually, one is the role of IPA and chronic ulcerative with the mid and low rectal cancer. I think we've just answered that. Then there's one comment: Lone Star retractor helps in mucosectomy. I think most of us would use a Lone Star retractor for a mucosectomy and a low rectal anastomosis if there's a Hansen anastomosis. Then there's a question: in which cases should mucosectomy with Hansen anastomosis be preferred over a stapled anastomosis? I think Sujay has already answered that. Maybe Sujay can answer it again if there's any. In which cases would you consider a Hansen today?
Hansen would be required in those situations where you are dealing with a high-grade dysplasia in the rectal stump. That is one. Or if there has been a previous malignancy in the proctectomy specimen associated with or without dysplasia, again, in those situations. And thirdly, in FAP patients, you may prefer to do a mucosectomy. And in most instances, if there is a chance or a situation where you have to do a redo pouch, it is usually you end up doing a mucosectomy and the conventional Hansen anastomosis. These are the 4 or 5 situations.
Right. I think most of the other questions have been answered mostly. Yeah.
I think we have crossed the time allotted to us. At the outset, I would like to thank Dr. Govil and all the panelists for participating in today's discussion on how I do it, pouch surgery in ulcerative colitis. Thank you, Deepak.
Thank you, Dr. Kapoor, and thank you for coming. I think it's always a blessing when you're there for these classes.
Thank you.
Thank you, sir.
Thank you,
Thank you, Doctor. Thank you. Bye.
Thank you.
Yeah. Thank you, sir.
Yeah. Okay.